So in today's lecture, we'll try to cover what the definition of type 2 is and explain in particularly what it is and how it compares with type 1 diabetes that we learned about. We'll explain the etiology and pathogenesis. We'll describe and explain the symptoms, explain how it's diagnosed, and describe the microvascular and macrovascular complications, of which are probably the most acute. And then finally, we'll try and talk a bit about the prevention. And then the following lectures will be more about pharmacological treatments, of which there are many, and the mechanism of actions of some of those drugs. So, what is type 2 diabetes? We want to understand what causes it. It's caused by, it's a serious progressive disease characterized by two fundamental defects and a combination of these defects. The first is the inability to respond to insulin, so termed insulin resistance. And the second is a dysfunction in beta cells. Either they're not working, they're alive but not working, or they're gone, completely dying, similar to what we saw in type 1, but it can vary depending on the patient. The key point is that the combination of insulin resistance / insensitivity along with insulin deficiency, where the pancreas is unable to make enough insulin to compensate for this insulin resistance. People with type 2 diabetes can differ in the balance of importance of increased insulin resistance and decreased insulin secretion that contributes to their disease. So the challenge is finding that right balance for we'll talk about that when we come for the treatments, and that insulin resistance becomes exacerbated by overeating, by inactivity, and other risk factors that we will cover later. What is the percentage of diabetes? Well, type 2 diabetes, well, it accounts for 90% of the diabetes cases worldwide, which is a staggering number. But if you think about it, and if we think about what causes type 2 diabetes, it actually provides some hope for getting a hold of this epidemic and for treatment, because some of the treatment is rather obvious. Despite the obvious nature of type 2 diabetes, it still represents a significant disease burden for the population. It's a question of cost, numbers, side effects. It's associated with serious microvascular, macrovascular complications, significant impact on overall healthcare costs. It can also impact on things like dementia. Remember, we had this term of insulin-dependent deficiency diabetes. Well, this is non-insulin deficient, but dependent, but it's not usually used, that term, anymore. So we'll stick to type 2 diabetes. Just remember to remind you, again, one of my favorite exam questions, the difference between type 1 and type 2. Type 1 is an absolute insulin deficiency, which causes persistent hyperglycemia. And that's because of all that cell death we saw, right? In the case of type 2 diabetes, insulin resistance and a relative insulin deficiency, which results in persistent hyperglycemia. Okay? It's not an absolute insulin deficiency. Some patients can still make insulin, they just can't necessarily respond to it. Now, we'll cover a little bit this in the developmental and pregnancy stages, but importantly, during pregnancy, women can get what's called gestational diabetes and become hyperglycemia. Hyperglycemia develops during pregnancy and usually resolves once the baby's out. Although the woman is at increased risk for overt type 2 diabetes following such incident. Other types of diabetes include monogenic diabetes, which is due to a single gene defect previously known as maturity onset diabetes in the young. You can also have diabetes secondary to pathological conditions or diseases such as pancreatitis, trauma, or pancreatic surgery. And you can get drug or chemically induced diabetes, such as from long-term corticosteroid treatment. So these are side effects from long-term treatment. But all of those have the same phenotype, and that is insulin resistance with relative insulin deficiency, not absolute. So what does this look like in terms of type 2 and onset of disease? Remember, in type 1, we had very quickly under sort of the age of 10, we had a dramatic drop-off. Here, it's slightly different depending on your glucose levels, and after you've eaten, you can see that in diabetics, as you progress through the disease, the glucose levels get higher and higher after you eat. And eventually, you start to develop that insulin resistance. So there is a window of opportunity to revert that before you're completely insulin resistant, and that's an important time to identify for people to be able to treat them. It's in that gray area here I'm showing you. But you can see that the insulin secretion drops dramatically after that gray area, and it's sort of a critical point. So how does this actually happen? How do people become insulin resistant like this? Well, it's not that difficult to understand. In many cases, it's the following, that essentially people just sit and watch and don't move, essentially, inactivity, and eating too much junk food. And this leads to, obviously, a phenotype where we are no longer in decent shape and we become obese and overweight, and what is commonly termed in the West a couch potato. I don't know if you have that similar term in China, but essentially you have people that sit at home and eat a bunch of junk food and watch and just play video games or whatever, and there's not enough exercise. So what does this do, and what does this mean? Essentially, it leads to the pancreas. Basically, you have the pancreas trying to produce insulin, and because you've got this resistance, you have your liver no longer responding. You have your lipolysis no longer responding. Remember, insulin is supposed to start blocking it and cutting down on the fat you store, right? And you no longer are achieving these things. And then this leads to gradually changes in, obviously, your metabolic state. And so insulin resistance is strongly associated with obesity and physical activity. And a number of circulating hormones that we've talked about originate in this adipocyte and originate down here in these adipocytes and then also in the liver. So if these two features become insulin resistance, they're no longer giving that feedback. Remember, we're all about feedback loops in the body. Then essentially that feedback is no longer provided because it's not responding. These tissues are not responding to insulin. This leads to an increased mass of triglycerides, especially in the visceral deep subcutaneous adipose depots. Leads to large adipocytes that are themselves resistant to the ability of insulin to suppress lipolysis, which then results in circulating levels of these non-esterified fat acids and glycerol, both of which aggravate the insulin resistance in the liver and the muscles. So it's a vicious cycle that feeds on itself. Now, what are the causes of these? Well, it can be multiple, but basically it's the development of this sort of visceral fat, which becomes so much that you start to develop insulin resistance. And you can see that these massive fat cells filling up this space that you can no longer achieve insulin resistance. And then gradually you start to see the fat forming in the liver, which again leads to gradual insulin resistance. So it's not difficult. If you don't move and you just keep storing fat, fat will start to impede on your ability to respond to insulin. What is a diagnosis of insulin resistance? How do you diagnose it? A very simple statistical way was to measure waist circumference. So in men, you started to have an increased health risk at greater than 94 centimeters, and then a substantially increased health risk at over 102 centimeters. For women, this statistic is slightly less at 80 and significant at 88. And then these days, this measurement is been transformed, so to speak, into something more common, which you probably are familiar with as training doctors, and that is what's called a BMI, body mass index. And then for in terms of healthy weight, we like to be under 25, and then people starting to be classified as overweight are at 25 and higher, with significant levels of obesity there within. So what about beta cell dysfunction and death? And remember, in type 1 diabetes, we had tremendous immune response and tremendous infiltration shown here with those black circles into and destroying the beta cells. In the case of type 2 diabetes, you can also achieve there is also some level of immune response, but typically for different reasons, not because there's an epitope, but more just because you've increased inflammation due to all the fat around, usually. There are some exceptions, which could have been, remember when we talked about drug side effects can sometimes drive this. Remember, when we had beta cells producing insulin, the whole point was that it promoted glucose uptake into muscle cells, which inhibits glucose production from the liver, which then promotes glucose uptake into the adipocytes, which then inhibits lipolysis. And finally, promoting glycogen synthesis and storage. In the case of type 2 diabetes, you've got insulin resistance. So all of those things start to go in reverse. Now you've got high circulating glucose. This decreased glucose utilization is now, you now find decreased use of the glucose. This leads to an initial increase in insulin production because the beta cells are trying to respond. And then eventually, what is called beta cell exhaustion and eventual failure. So the beta cells start to die because they essentially can no longer produce insulin. They just essentially they've used all their ATP. They can't do it anymore. And this is what causes the primary cell death in type 2 diabetes. So it all comes down to, in many cases, that fat, which drives the insulin resistance, which increases the circulating glucose because you're not using it anymore, and you're then trying to respond by driving up that insulin production. So what about the people, remember I mentioned there is a small portion of the population which have a genetic predisposition for type 2 diabetes. So what is the percentage of this? So positive family history can confer a 2.5-fold increased risk for type 2 diabetes, with 15 to 20% of first-degree relatives of patients with type 2 diabetes developing impaired glucose tolerance, IGT, or diabetes. At age 80 for type 2 diabetes has been calculated to be 40% if one parent had type 2 diabetes. If both parents are affected, the prevalence of type 2 diabetes in the offspring is around 60% by the age of 60. Now, what are the genes? Well, it's complicated, but because there are multiple genes that can be put people at risk, and it's termed polygenic, but it's not HLA related. Remember, type 1 was HLA related, and type 2 diabetes is not. So what are some of those risk factors? Well, we've got PPAR gamma, which is peroxisome proliferator activated receptor. We've got glycogen synthesis, as you can imagine. It's responsible for the metabolic side of things, and if you've got some sort of defect or deficiency or slightly less active enzyme, you can imagine it starting to become a problem. You've got insulin receptor substrate 1. You've got proinsulin, INS gene, and for obvious reasons. You've got, remember, the potassium channels that were opening and depolarizing the membrane. Well, that's obviously a key factor if you've got certain point mutations. In this case, a lysine 23 point mutation. You've got another potassium channel, this ABCC8. You've got glucose transporter. Remember, glucose is transported back and forth. That was one of the key steps in our process at the beginning. And you've got PPAR gamma coactivator, so related to the top. Again, a transcriptional factor. If you remember, we had transcriptional changes caused by glucose and eventually insulin. And finally, there's calpain-10, which is part of the processing side of things in terms of the endocytosis and transport, maturity of insulin. So what about this monogenic diabetes that I mentioned to you? It's a very uncommon form of type 2 diabetes with less than 5% of all type 2 diabetes cases. It typically occurs before the age of 25. It's characterized by very slow onset of symptoms. There's usually no obesity related, no ketosis, and no evidence of beta cell autoimmunity. And the nice thing is it's often managed without the need for exogenous insulin. It does, however, display an autosomal dominant pattern in inheritance, generally spanning about 3 generations. So far, there are 6 known forms of this identified, each associated with a mutation in one different gene that is directly involved with beta cell function. In the case of these genes, you can see here the known 6 monogenic phenotypes are here. You've got HNF4A, GCK, HNF1A, IPF, HNF, and NeuroD1. And the number of mutations for GCK and HNF1A are quite high and account for the majority of the monogenic forms of type 2 diabetes. We'll cover more in terms of treatment, but you can see here that diet is a major aspect even for these forms of diabetes. So, what are some of the symptoms of type 2 diabetes? How do we know if a patient has it? Well, we mentioned, remember the name of diabetes had to do with siphoning liquid and having sweet glucose, high levels of glucose in the urine. So polyuria is probably the most common symptoms of frequent urination. And then related to this, polydipsia or increased thirst. And then also polyphagia, which is sort of increased hunger. Later, you start to get blurred vision in one or both eyes, get dizziness and dehydration, fatigue, lack of energy, and then in some cases you can get yeast infections. And then later, more dramatically, you start to get slow wound healing. So that's the development of sort of nerve damage and infections. All of those start to get quite serious towards the end there. So how do we diagnose type 2 diabetes? Typically, we work via glucose tests, and specifically, remember, we talk about the timing of testing is quite important, and this also becomes an issue for glucose. So the first test for type 2 diabetes is this random plasma glucose test, or RPGT. So first, the patient comes in, blood is drawn and tested for glucose levels without any fasting. And typically you want levels that are below 11 millimolar per liter, 200 milligrams per deciliter. If the results are significantly above that, then patient needs to be viewed further and probably has diabetes. The second one is this fasting plasma glucose test, or FPG. And that is, well, it just depends on the doctor which one's used, to be honest with you, but is often the more common one. So patient is asked to not take in food or drink for 8 to 12 hours before the test. blood is drawn from the arm for glucose level testing. And then again, what you expect to see is below 6 millimolars is normal fasting blood glucose, and then pre-diabetes is 6 to 7, and then if it's above 7, you want typically a patient has diabetes. If there are no overt symptoms, then you do a follow-up test called an OGTT, which we'll talk about, and that's the oral glucose tolerance test. So again, in this case, the patient is asked to fast, but in this case, when the patient comes in, you give them a glucose-rich drink, and then you take a blood sample after 2 hours to measure blood glucose levels. And what you expect to see is now a change. So you would have before, remember, below, and now if you expect to see a change in those levels, but it's still below 7.8. If it's between 7.8 and 11, it's again impaired glucose tolerance, and if it's above 11, you've got full-blown diabetes. So green here would be blood glucose concentration levels after that glucose intake for that OGTT. You can see for a type 2 diabetic at 1 hour, it was going to look kind of similar, but at 2 hours, it's still quite elevated, right? And the numbers are through the roof in the case of the type 2, whereas for a normal, it's going to peak at about 120 at an hour, but it will drop very quickly. So if you're measuring, remember for the test, we're measuring here at 2 hours, you can see significantly lower blood glucose levels for the normal patient compared to a type 2 diabetic. So the summary for the oral glucose tolerance test is the patient fasts overnight, you bring them in, you give them a very sugary drink, and then you measure their levels, their glucose levels. And you should see after a 2-hour plasma glucose, normal levels below 8, diabetes levels above 11, and kind of impaired between 8 and 11, sort of pre-diabetic. Okay, why don't we take a short break here, and then we will finish it off with the second half.